So the next presentation, interventions in acute portal and mesenteric vein thrombosis, will be presented by Stoyan Handzhiev.
Good afternoon. First of all, I'd like to clear up one misunderstanding. I'm gastroenterologist, by the way, and the title of my presentation is hepatocellular carcinoma with portal thrombosis, vein thrombosis, diagnostic and therapeutic algorithm, the light of the current guidelines and recommendations. I'd like to thank the organizing committee, and I'd like to share our experience together with our friends and our colleagues from Cardiology Center. We're working very close, and this topic is our common topic. So the starting points, of course, HCC and PVT is between 16 and 30%, as you see, and it announces one advanced disease, poor prognosis, and in the near past, they were candidate only for palliative and systemic therapy in some cases. Our key point for management of this problem is the BCLC system, staging system, first with some modification, of course, as well as the kind of diagnostics, COS, Doppler, B-flow. By the way, we use in our everyday practice US diagnostic as a first option in the diagnosis of HCC, and with the new applications such as contrast enhancement, B-flow, as well as with Doppler, of course, we can find earlier detection. We can early detect portal vein thrombosis in cancer patients. The therapeutic options, of course, are dictated by EASL. This is European Association for Study of the Liver, American Associations of Study of the Liver, National Cancer Comprehensive Network coming from USA, Chinese guidelines, and Korean, as well as Taiwan. By the way, as we'll see, these Asian chaps, they're much aggressive with their attempts to decide this problem, as you'll see a little bit later. Of course, the multidisciplinary team, MDT, is the key points and the starting point for the final decision in these cases. Classification, I will not be very much in detail. You see the different classification options. They're equal in their interpretation. Nevertheless, I should say peripheral and central are the main topics in this case. Diagnostic US Doppler with Doppler, COS, and B-flow, as I said, our tools as gastroenterologists in the very beginning and the debut of the problem. So I should say that in the new machines we're working with, I mean ultrasound machines, we have the options with the MVI, which is microvascular imaging techniques, which can define, especially when combined with contrast enhancement and B-flow proceeding, to see the peripheral parts of the portal vein thrombosis as well. Of course, the referential imaging techniques, CT angio, and with their high sensitivities in the field of multi-detector detector machines, as well as magnetic resonance techniques. I should say only one detail for the PET-CT. Of course, it is not in our guidelines as the very beginning to put the diagnosis, but in some cases we have this weapon in cases with HCC, because there is a specific element. This is the so-called fibroblast associated positron emission imaging, or for short FAPI. We can use it, by the way, better in our everyday practice, working with our colleagues from the nuclear medicine department for follow-up of our patients with HCC, with HCC without PVT. This is the therapeutic algorithm nowadays, and you can see that the situations I mentioned before with PVT and HCC measured and defined as non-curable, non-treatable, instead of except palliative and symptomatic treatment. You can see that that trends are changing. And again, the new wave comes from Asia, from Korea, from Taiwan, from China and Japan, of course, who dictate the mode, the fashion in this problemacy. I will not stop in detail. You can see yourself what are the options, even with the means of downstaging. Hepatic with the TACE, with the SBRT, this is selective body radiation, as well as with HIKE. We don't use HIKE, by the way. They used to use it, this technique, in the colleagues in Darvinica, where is the National Center, Oncology Center. But you can see that Chinese, especially Chinese and Japanese experts announce good results after downstaging with TACE, SBR, and TE as well, even for the patients included according to the Milan criteria, as well as San Francisco criteria for transplantation and hepatic resection, or RFA, which are radical options of treatment. Of course, over first order branch, according to the guidelines of these experts, they're going to systemic therapy. Systemic therapy nowadays also a very, very strong weapon with the means of with the representative of the target therapies as well as immunotherapies in some cases. Here are the guidelines nowadays as a management of advanced hepatocellular carcinoma with the portal vein thrombosis, according to the various international guidelines and recommendations. Here are cases which are shared with our colleagues from Cardiac Center, and you can see 18 patients with HBV. By the way, hepatic B viral cause for HCC is the leader as a cause for hepatocellular carcinoma. In our cases also is not an exception. We have done targets therapy with sorafenib, lenvatinib, and regorafenib in 3 cases. Immuno. This is the new weapon of oncologists. This combination, desolizumab with bevacizumab, and we use it in our practice, of course, as well. Thrombolysis were done in 6 patients, as well as TIPS, 2 patients. I want to thank Professor Velchev, because some of our TIPS patients are coming from his department. And all of them have been on systemic anticoagulants. This is what our colleagues 2 years ago presented on your super congress here, I mean in 2023. And here are their cases which they presented, and some of them, these 6 patients with HCC, are patients coming from our department. Here is a case from the newsroom. No, it's not from the newsroom. You can see 22-6-year-old patient with HBV cirrhosis and so esophageal varices with PV type 3, TACE and thrombolysis, and afterwards with atezo-beva systemic treatment as well. Sorry, here is the picture from the CT scanning. You can see it very well. And these are the descriptions of the procedures done, TACE and thrombolysis as well. And this is the picture coming from our colleagues from the cardio center, who we are working with very close, and I thank you for this option, to have this option to work with such good expert. And here are my conclusion, which are there are several different treatment options for HCC patient with PVT, but the treatment plan for each patient should be personalized depending on the performance status, stage, and extent of portal vein involvement by tumor thrombus, presence of or absence of nodal disease, and distant metastasis. Combination therapy yields better outcome. The combinations and sequence set remained largely unanswered and need further prospective studies, of course. The thrombolytic therapy predicts a better outcome, quality of life, and survival. Thank you very much. And I have the pleasure to show our tumor board, including our experts in interventional and vascular procedure, angiologist, and all the others you can see on this picture. Thank you very much.
Congratulations. I think we have a unique experience because thrombolysis is not widely adopted for specifically this pathology. And there were some paradoxical results. So last year that if you anticoagulate these guys, the rate of recanalization didn't change, but they live longer. So for some reason, I think hepatologists now are starting to move a little bit to the cardiology philosophy.
Yeah.
And do you think how durable is this result? So after you have some improvement of the flow in the, and you follow them?
Yeah, of course. Yeah, we follow up, and we follow up according to the protocol, and sometimes beside the protocols, because such patients are common patients. They are not only ours; they're patients of the endovascular experts as well. This is why we don't have any conflict of interest. We don't have any, and I think this is the method of following up, to do it together. We follow up every 6 months patients with HBV according to the protocol, with and without HCC, and we find this is another topic, of course, but as a follow-up, we do it, gastroenterologist, more closely.
Okay, thank you so much.
I thank you.